we like them to be honest and accurate as much as possible. So we document everything that the client is telling us. So for example, I can ask you, what did you have for breakfast this morning? You may say, I had cereal, but I need to know what type of cereal. You may say, I put milk in the cereal. I need to know what type of milk. Is it low fat or skim milk? Juice, what type of juice? So we probe follow-up questions so that we can get the information that we need in order to advise the patients. And as I said about the over-the-counter medication and vitamins, etc., we need to know. And fiber supplements like Metamucil, which these things has psyllium gum, which is also good for lowering cholesterol. But one of the problems you may be seeing is nutritional supplements. Some people who may have diabetes may just go and take Boost or Ensure, and they may be taking the wrong Boost or the Ensure. Some of them may be taking even the Gatorade, which they think will give them the energy. So these are the things we need to know to advise appropriately. We do try to set realistic and achievable goals, address the barrier to change, and we suggest alternate behavior. And these things are given in writing. Patients' perception, some of the barriers, lack of positive reinforcement, these are some of the things that they meet, lack of commitment, depending on what stage they are at, determine their change, misunderstanding the information, hence the reason why it is important that the client come back to us. So sometimes when they come back to you, you go back to see the dietitian, etc., because it depends on where they are on the stages of change that they may need a follow-up. And unrealistic expectations. Some people may come in, they are 250 pounds, they're supposed to be on 50 pounds, and expect within the month that they lost all that weight. So we have to say that it did not come on, it did come on gradually, so the loss will have to be gradually. So what we try to do, not to lecture and judge the patient or criticize them. We do low potential asking questions. So we ask questions, we give practical advice, we make realistic suggestions, we proceed with logic instead of criticizing, and we offer solutions to the patients. And these are some of the stages of change that we use in order to determine where our patient is at. So that somebody may be pre-contemplating or somebody might be preparing for action. Where they are, the stages of change determine when we will be able to give them a follow-up. If they're pre-contemplating and they still have not, to change their lifestyle, they get an early follow-up. Compared to someone who prepared for action, they get a longer follow-up. So it depends on where they are. For example, this is what we may suggest if in the pre-contemplation stage, little or no desire to eat fruits, etc. We try to explain to them the benefit of eating the fruits, etc. They don't eat fruits, and how many of you in the audience eat fruits and vegetables on a daily basis? Someone said, I don't like it. From a child, they're growing up and they prefer the hassle of taking fruits or cutting up fruits. They will drink a V8 juice. But some of the things is that sometimes the V8 may have lots of, it depends on what it is, may have a lot of sodium. If it's for tomato juice, they may be consuming, etc. So we sort of advise appropriately. If they're contemplating, they understand the benefit, but there are certain skills that they may be lacking. So we tend to suggest them certain skills that they may be to benefit them. For example, they may think that food is expensive, but what we suggest is that we do buy frozen fruits, so that if fruits are in season, fresh fruits, that you can buy these things and freeze it. Vegetables you can purchase when they are in season and they are cheaper, and you can blanch it or leach it and freeze it. And in that case, you get healthy fruits and vegetables with retaining their nutrients the way that you leaching it and freezing it immediately. So, as I said, we identify and discuss the barriers and give information for the client or patient to follow through. We prescribe small changes. So if you tell me I don't eat fruit at all, I suggest maybe twice or 3 times, or gradually increase like 1 per day, etc. We normally say 4 or 5 fruits a day, but we can start with 1 and we can build up on a daily basis as we go along. If you do relapse, no one needs to be perfect, we suggest to them. And what we look at the fact that we encourage the person to get back on track. So that you may go and think that you lapsed because you went to a party and you ate certain things. Okay, that has gone by, but then you'd go back on track and start your plan. It's not going to affect you drastically. So hence the reason why, yes, if you do relapse, go back on track and you will be able to go ahead with the plan that we have given to you. So let's, for example, we are speaking about healthy eating. What do I mean about healthy eating? I'm speaking about choosing food wisely from 6 food groups, the food groups that we use within the Caribbean. Eating 3 meals and snack if necessary. And when I'm speaking about snacks, I'm not speaking about corn chips and cornflakes, corn chips and these stuff. Keeping a healthy weight, we'll discuss that, and preventing or delay complication of certain chronic diseases. This slide shows the Caribbean food group, and we have 6 food groups. And you can see we have the staples, the legumes, the food from animal, fruits, vegetables, and fats. This is for the general population. Because if we have a client who has coronary heart disease or diabetes or triglycerides, we would not give them as much as the staples that we have here. The fats, we will determine what type of fat to advise. So we will modify this plate group and advise the client, depends on the medical condition, appropriately. This other slide will show you a slide that was modified by PAHO, and as you will see, it does not have as much of the carbs or the staples, 32% instead of having more than close to half of the plate. Our legumes, or food from animal, fats and oil, and you see vegetable has increased considerably in this, and you have a small amount of food and water to be consumed instead of juice, etc. So this is a modified plate that we can give to our patients, especially people with diabetic, etc. Here I have the traditional Mediterranean diet pyramid. And this Mediterranean diet has most things or everything that we try to tell our patients using our food, plate model. It has physical activity. And as you can see, even though we have all the fats, all the food from animal lumped together, the Mediterranean is advising that you have like a red meat monthly, so that we use this sort of approach when we are advising our patient that, okay, have less red meat, have it, etc. We tell them the type of red meat. And you see the carbs, but the type of carbs that they have at the base of the pyramid is more the grains, the healthy grains, the whole grains. And you see the fruits and vegetables a little bit more than fruit. They use a considerable amount of olive oil, cheese and fish and eggs, but the red meat is on top. And as you see, they do drink wine in moderation, and they include their water. So we modify our plate model to suit this type of consumption of food, because what has been shown, a lot of research has shown that Western dietary patterns, the way that we eat, compared to how the Mediterranean dietary patterns lead to an excess of production of inflammation, which is responsible for some of the problems with coronary heart disease that we are having. So the Mediterranean diet, if you look at it, and I identified it in a way that it shows you the type of food within that pyramid to reduce inflammation within the body. Okay, the next slide now, this is from the IDF, International Diabetes Federation. And at times what we do, we take a good food, as I can say good in quotation, and we prepare it in a bad way, using that phrase. So that preparation of the meal is important. So it's how you prepare the meal is also important. So for example, we have rice, but you're going to fry the rice. It makes it unhealthy at that time, or less healthy. The noodles or bread, the rotis. For example, instead of butcher shop, you can use the sada roti, or even the dal puri, which will go in the yellow zone. Potatoes, instead of the french fries, you can bake your potato. Steamed vegetables, but you don't put a lot of mayo, etc., with those vegetables. And your sauces, or even your fish. We fry a lot of fish within the Caribbean. So these are the things that we advise, the same food that you're consuming, preparation, and we do advise about preparation when the clients or patient comes to us as dietitians. There's a pyramid here that we also have vegetarian and vegans who come to see us. And we do have to plan for these patients. And hence the reason why I slid this slide in to show that we use this plate model also to advise our vegetarian patients. So those are the foods that we have, how we adopt our eating habits with the plate model and the other types of models that we have where food is concerned. So let's look at obesity here. And this is a WHO classification of obesity. And we are asking people to be between 18.5 to 25 in order to have a healthy weight. For female, 18.5 to 24 is ideal. Male 20 to 25 is ideal. But as we know, and once you go above that, you're going to grade yourself into different category of obesity. BMI alone and waist, it is not always ideal. What you also have to look at is your waist circumference, because you can have a healthy BMI and you can have a large waist ratio, which also predisposes you to cardiovascular disease. So that for ladies, we suggest, and this has 35, and normally say less than 34 inches your waist is supposed to be, and men less than 40 inches. And you have a healthy BMI and a waist ratio within the normal limits, which will be a healthier waist, so that we have a lot of people could have a healthy BMI, but they are over fat. So this is one of the suggestions of keeping your waistline small, below 34 for female, and male below 40 inches. And the Asian population has adapted because of some research, their measurement, and the only change was for the Asian men. It has been reduced from the European, whereas all the others stayed as 80 for women, either whether you're European or South Asian or Chinese, but the only change is that the Japanese is more than the 80. But for men, for the South Asian men, it's supposed to be equal or less than 90 centimeters. So that has changed. And like Professor T. Logson has a tape measure that on one side he has for the Africans, if he come, you measure, and on the other side he has for the Asian. So the South Asian male will have to be less than the 94 centimeter that the African male may have. We also have to look at waist to hip ratio. And in your measurement, the female should be less than 0.85 centimeters and the male 0.90 centimeters. And as you know, it is the waist is the smallest circumference below the rib cage, and the hip is the largest one at the posterior of your buttocks. And it is important when we are doing waist to hip ratio that we use the right tape measure. It has to be a stretch resistant tape. And the tightness of the tape, you must determine that, so it must not be too tight. And you must have it in the correct position, parallel to the level where you are taking the measurement. And it should be snug around the body, but not too tight. And you have to get in order to get the correct ratio that you're looking for. So as I said earlier, high BMI may be due to excessive lean body mass, so that BMI alone is not that important. Fat measurement is also important. So if you look at this slide, you will see both of them have the same weight, but both of them have the same BMI, but one BMI is more of muscles and the other one is more fat. So BMI is important, so we have to use clinical judgment. Like in my practice, I normally have a body composition that will give me your pounds and muscles, your fat in percentage, even your water level, visceral fats, and even your metabolic age, etc., so that it gives me a broad description of the individual, so I know exactly what I am dealing with, so I give the appropriate plan. And here we looked at body fat content, and again, as I said, you can have a normal BMI, but your body fat is high. So we're looking at someone, at this slide is saying normal is 13 to 21 for men and 23 to 31 for female. But then again, at an older age, your younger age group, even for 25, if you have for ladies, if you're between 23 to 25 is better. And the older ladies, even give us a little more leeway. but we tend not to be, anywhere between 25 to 30. But ladies, you're supposed to be anywhere between 23 to 25. This is not for athletes. Athletes are different. Athletes, men, 5 to 10, 9% body fat for a male athlete is one of the best. And ladies is 12% is one of the best for lady athletes. So again, it depends. This is more for the general population, this slide. So when we do, you can also be doing percent body fat for your children between 7 to 18 years. And this is a chart that can be used to determine whether they're on the fat, healthy fat, or obese, and to see how they are trending. I'm not sure which of the charts that you'll be using in the health centers, but we have the CDC and we have the WHO, and I know from previous lectures that some health centers use CDC and some centers use the WHO. But important for us to do the BMI and do the BMI for age so that we do the percentile to tell us the overweight for the individual. Child obesity in Trinidad is increasing. And in 2001, Professor Tillotson and a group, and Dr. Simeon and myself, we looked at obesity, and we did get 7% in 2001 and 5% obese. 7% overweight and 5% obese. In 2011, repeating that study with Professor Tillotson, we got 17% overweight and 15% obese. So you see, within 10 years, there was a tripling of obesity. But in 2018, Professor Tillotson, I was not involved in this study, Professor Tillotson and a group looked again at overweight obesity in children. And as you can see in 2018, it's 51%. So there's a secular trend in obesity. And if we do not try to capture this increase that we are having, we're going to have major problem with cardiovascular disease with our children who are going to be adults soon. We also identified type 2 diabetes in this group. Professor Tillotson and myself and the other group, we identified in 2011 type 2 diabetes in some of the obese children that we looked at. And why this slide is here to show you that the cases that we may have is so much higher compared to Japan and Canada. And I'm just using this tree to show you. In Europe, in the UK, it was less than 1. So what this slide is showing you that with obesity, we are increasing. And obviously, our trend in type 2 diabetes in children is also increasing. And as we know previously, type 2 diabetes used to be for the adult as we get older. One of the problems that we are having with our children is because of the overweight that they are having and lack of physical activity that we are having. The only country that was higher when we looked at it was Kuwait. They were 48% or 40-some-8 cases compared to our 30. So we have a problem with childhood obesity. We may have a healthy child, and then because of certain factors in the society today, our children are putting on weight and they're becoming obese. The fact is that sometimes we tend to like chubby children, but if we continue for the chubby child, get mildly obese and then moderately obese, and when they become a teenager and they attend secondary school or even in primary school, they are challenged and they are bullied. And then we may see our children not eating, they become anorexic, or they may have bulimia, etc. So we have a vicious cycle of obesity, may cause certain medical problems. And also, these children, if we don't do something about it, they'll become obese adults. So what is the problem that is creating the problem with our children? Is it is it the high fructose corn syrup that we are providing to our children? Is it the portion, the supersize, or the type of food that we are consuming at this point in time? Because value for money. That previously we used to have a small burger, now the burger cannot fit into your hand. So some of the problems we are having is dietary intake, increased portion size, increased frequency of eating out, fat-free perceived as low calorie or calorie-free, so we eat much more and then get more calories than if we had eaten food that has fat in it. and we do have increased fast consumption. So dietary intake is one. Physical inactivity is another one that may be creating some of the problem. For example, if you look at previously and to now, that we are now in going to car wash, we play video game, we watch a lot of TV, etc. So these are some of the things that less energy is expended, and the labor saving devices that we have in the house with our children and ourselves, that we are not moving as much as we used to before. As you know, what goes in goes out in order for you to maintain ideal body weight. And we tip the tail depending on what. If you eat extra, obviously, and you didn't expand, your weight is going to increase and vice versa. So these are some of the things that we have to increase in order for us to deal with the obesity problem that we are seeing happening in our population, starting from our children to the adult. I didn't put the percentage for the adult. I did put for the children because the children are the ones that we really have to look at now, etc., to prevent them from getting the condition of NCDs as they get older. So I'm not sitting here to say that there's any simple answer to the obesity epidemic. There's a number of factors that contributes to it, as you see in this slide. And the only thing that you might not see in there is crime that prevents us from walking outside, etc. But these are some of the things that are responsible and that we're supposed to sort of be dealing with some of these, because the Ministry of Education have already started about not stop drinking schools, etc. And the Agriculture Department is also doing their work, etc. So we are looking at some of these things, but there's much more that we can do in order to help with the problem that is creating the obesity epidemic in Trinidad and Tobago. So moving on. So if we speak about obesity, sometimes a client may come to you, patient, and they will say, but I was a normal weight last year around the same time. And I'm not sure why it is that I am overweight now and having some medical problems. It is not that the person was picking out. The fact is that if we consume as little as 100 calories a day, and we do not expend those activities, that 100 calories, it adds up. And at the end of the day, we realize that we have put on weight. And it's not because you're eating so much food and I'm picking out. It's because a little extra chocolate that you can resist after dinner may be creating. The pack of nuts, instead of eating half, you eat a whole one on a daily basis. And that is what is the problem that we are having, this condition creeping up with us in Trinidad. So I'm just changing here to break the ice. Here we have some chicken and chips. This was done at San Fernando Hospital a couple of years ago. And this was supposed to show you the calories. Look how much calories in this chicken and chips. Nearly 1,000 calories. But what I want to focus on is the amount of sodium. Over 1,000, 1,500 calories. So what is If we look at this hamburger, look at the sodium and look at the calories. And this is that you may have that alone for lunch. And you see sometimes why our hypertensive population is like that. But sometimes someone comes to us and they said, this is what I eat and this is what I'm going to get at lunch. We have to look at this to see how we can modify this. Can you modify that to make it healthier for the individual? I know in some of the classes, some people were making some joke and said, take out the lettuce and the tomatoes, or even the, but coming seriously, we can modify this so that a person will have less sodium and less calories and still get a burger to eat for lunch. So it's modification and it's what you put in it. Even that sort of mayo at the top, that could be avoided in order to make it healthier, and maybe change the bread to a whole grain bread. Pizza, again, I focus on the amount of sodium in this. The calories may be half of what we saw with the others, but look at the sodium. And this is just one slice. How many of us eat one slice? And then we have the doubles. Yes, it is only 200 calories. How many of us eat one? Maybe now we might end up eating one because we cannot consume the doubles at the doubles person, and we have to put it in the bag. So we are limited. Instead of sitting down there, standing here, eat 3 or 4, and then fill our bag and eat more. So again, there's supposed to be some control. So we are not saying not to eat. We are saying modify so that we can get less calories and less sodium in some of the foods that we purchase. Again, I'm just looking at this meal here and asking, is this filling? Can we modify this? And again, that is where dietitians we come in. So somebody presents us with this and we need to, I am not filled. We need to know how to modify this so that the person will be able to consume the meal. So maybe what we can do, take out the fat and have less meat. It's 6 ounces of chicken there. Maybe we can. How can we modify this to make it better? Maybe you can put it on your chart. I'm not seeing the chart. I may have to change my slide because it's taking up my whole thing to see your chart or what you may be saying. But how can we modify this to make it more satisfying? So maybe you can write that down on your slide, on the chart, which I'm not seeing anyhow. And there's water that you can put some lemon in it. Here we have cereal. And if you're diabetic, we tend to advise you to have half of a banana. And then that type of cereal, we will tend to have more oats, rolled oats also instead of the cornflakes, etc. So again, the person eats cereal for breakfast. So then we will modify it and say, instead of having that, have oats and have half of a banana. And maybe some of that milk that you may be, and they have black coffee or tea. If they use milk, then they can put a little bit of milk in the coffee or tea, but no sugar. So again, we modify what they may eat to satisfy the medical condition that they may have. So looking at portion size, a face of a Julie mango is a serving of fruit for a diabetic. So again, if you eat the whole Julie mango, it's talking about 180 calories. So we normally, because of the sugar content, we normally advise half or 1 face of a Julie mango. A banana, a large one, half is a serving that you will a small apple, 2 plums, and those are the servings of fruit. So when I say a serving of fruit, I'm speaking about small apple, face of a Julie mango, etc. When we are speaking about nuts, a serving of nuts has 80 calories. 11 almonds is a serving. 8 halves of walnut is a serving. So when we eat a whole pack of nuts or almonds that we may purchase and think that we are not eating, it's about 200 calories. So we are taking more than 2 servings and we are not expending. And again, like I said, on a daily basis, if we do that, we do put on the weight if you are not expending to get rid of the extra that you may be consuming, because normally things are eaten as snacks and not as a meal, and you still count your meal as when you sit down and eat your food. Soft drink. A 12-ounce cola has about 150 calories, which is about 10 teaspoons of sugar. So hence the reason why we tend to ask the individual juice or even soft drink. That is 4 teaspoons more than most of you ladies should have in an entire day, and one more than most men. So we are trying to ask people not to consume soda, soft drink. And that soda, again, is not a good substitute, because research has shown that the artificial sweetener shows off your metabolism and it can even make you put on weight and increase your risk for diabetes and heart disease. So we try to say not lose that sugar sweet habit and not to consume either the diet soda or regular soda. Some alternate, you can use sparkling water, you can put a little bit of juice, but not the full glass of juice, because the juice itself, a half glass of juice has 60 calories. Whether they tell you that it does not have sugar. So we still have to look at that. And these are some of the things that we use. So you can splash it. I'm not saying not to have some, but you can splash it. You can use lemon water with mint or in order for you to have some, to drink, or just water, the lemon in the water itself. So these are some of the things that you can use to cut back on some of the fluid that we have, because we are asking people to be hydrated. So let's look at some of the factors that affect serum cholesterol. High saturated fat, high cholesterol, and obviously if you eat extra, you don't expend and you put on weight. You will know, and I will just briefly run through that, saturated fat and unsaturated fat. But the fact is that we know that saturated fat definitely affects blood cholesterol. We know it is solid at room temperature. And your sources include butter and cheese, meat, and these are natural saturated fats in our food products. Baked products will have the unnatural saturated fat, which I'll speak about trans fats later. So saturated fat is well established for heart disease. So this slide is showing you that there are some that we said we should not have at all, like those marbled sausages and hot dogs, etc. But then there are some with the special dark chocolate, which we will say, yes, you can have because of the polyphenols, etc., and that is good for the heart. But an excess amount of it is not good for the waistline. So we try to say just 2 blocks if you need to, but not a whole bar. Coconut itself may be healthy. But one of the things that I need to say about coconut oil is that there's a big hype about coconut oil and it is so good, etc. Research definitely has shown that MCT oil is effective and it is good for lowering. We use it because it does not go through the long chain fatty acid route for metabolism. So that is, MCT oil is excellent. However, although coconut has MCT oil in it, it has more long chain fatty acid, which goes through the long chain fatty acid process. So the research that was done on MCT oil was not done on coconut oil. So all the information that they took from MCT oil and saying coconut oil and belongs to coconut oil, it is a fabrication of the truth. So what I'm saying, I'm not saying it may be healthy, but the excess amount that we tend to be using, that people use it for everything, we have to be careful because it's still a saturated fat, and saturated fat increases your cholesterol in your body. And that is all I needed to say about the coconut. Processed meat that has a lot of salt and fat, again, we advise about swapping. So instead of the cold cuts, you can use fresh turkey, chicken, or fish and slice it. Bacon, etc. You can do spicy veggie sausage. You can do your own, or you can use kidney beans or black beans in chili instead of putting sausage in chili, etc. So these are some of the swaps that we can do in order to have, yes, the same food in a modified way. So that was unsaturated fat. Now we are looking at unsaturated fat. You know that unsaturated fat is liquid at room temperature. You get it in fish and plant foods. So we have mono and polyunsaturated. And monounsaturated fat is the fat that is used in the Mediterranean diet. And the source is olive oil, which is what they use a lot. Canola oil is also monounsaturated fat, and certain nuts like pecan, almonds, etc. Avocado, which we have a lot of when it's in season here, monounsaturated fat. Research has shown that monounsaturated fat reduces your LDL cholesterol. It has no effect on your HDL. That means it does not reduce your HDL cholesterol. And what we suggest is that because it's heart friendly, in your total fat, you should have more of monounsaturated fat within your diet. The polyunsaturated, which is the omega-6 and omega-3s, which we need to get from our diet because they have the the essential fatty acids, and we have to get it from our diet. So we get it in your soybean oil. We have the flaxseed, which most people know about flaxseed. We get it in walnuts, and we get it in fish oils, salmon and mackerel and sardines, etc. We get omega-3, and we also have, that's the polyunsaturated fats. Sources of cholesterol, and we know about our cholesterol: red meat, egg yolk, cheese, butter, margarine, etc. We are suggesting that you should not have more than 300 milligrams of cholesterol a day. And as we see, one egg can give you about 186 milligrams. Previous, we used to say that you could use only 2 whole eggs a day and maybe use egg whites, but the research is showing that 1 whole egg a day does not have no drastic effect on your cholesterol. So you can use your 1 whole egg a day, including the egg yolk. But if you want to use more egg, you can add egg whites to that 1 whole egg and increase your egg, the total amount of egg that you have. 12 large shrimps has about 200 milligrams of cholesterol. The fact is that as soon as someone says that they have high cholesterol, they stop eating shrimps. But if you want to eat shrimp to get the omega-3 fatty acid, you can have less. So you can have 8 large shrimps or even 6 large shrimps in order to get. Do not remove it if someone wants to use it in their meal plan if they have high cholesterol. Trans fat. It's now being advocated that it's even worse for your health than saturated fat. Like I said, the natural saturated fat are things like etc. The saturated fat that is made in the lab, because it goes in the trans position, whereas the natural saturated fat is in the cis position, which is less effective than the unnatural saturated fat. So we use a lot of those trans fats in margarine, shortening, snacks, baked products, etc. It's advised that maybe if you can have less than 1% of your total energy comes from the trans fat. The thing about it is that all our snacks and other things are from trans fat. We have margarines, etc., that has trans fat. So some of the suggestion that I normally will give is that if you're having these snacks items, maybe what we can add to your batch of snack items for your friends, etc., add some nuts and some fruits in the midst of it, so that you wouldn't eat all the snacking with the trans fat, but you can have some nuts and other things that helps with inflammation, etc., within your body. Again, you can advise your clients, your patients, to read labels and look for trans fat and try to avoid a hard margarine. And if you look at the margarine that we have on the label, you will see that in it you will have beta-carotene, which is an antioxidant. Some of them will have vitamin E, which is an antioxidant. And because these trans fat causes free radical reaction in the body, the antioxidant helps to fight the free radical reaction in the body. And hence the reason why you will see in those stumped margarine there is beta-carotene and other antioxidants to help that situation in those trans fat. Even though they may have that, we still tell people to go easy on that. It may be easier or better for you to use butter, which is a natural saturated fat, than trans fat, which is unnatural, but have less of it still. So that intake of trans fatty acid definitely raises your total and LDL cholesterol, and it reduces LDL cholesterol. So that's why it is even worse than your saturated fat. Monounsaturated fat reduces your LDL cholesterol, but it does not reduce the HDL. And polyunsaturated fat reduces your LDL cholesterol, but it also lowers your HDL cholesterol a little slightly. So hence the reason why monounsaturated fat is given we are told that that's why monounsaturated fat is the better fat to use, because it has no effect on your HDL. However, even though I'm saying one is better than the other, we still have to have less total fat in the diet, because fat is fat and it can increase your total body fat if you are not excreting, if you are not exercising to get rid of the extra energy that you may be putting in. And this is just a summary of preventing coronary heart disease. Other issues that could be considered is vitamin E, folic acid, certain soluble fiber, alcohol, and fish. I'll be just speaking quickly on a few of that. Vitamin E, nuts. That's why I'm saying that you can use your nuts when you're using these trans fat snacks that you have. Margarine, like I said, vitamin E, even some of the mayo, they put that because of the trans fat. And certain you get supplement of 400 international units as you get older if you have risk for coronary heart disease. And these are some of the nutrients that you can get in nuts: monounsaturated, poly, fiber, etc. They're good bit of protein, vitamin E. Folic acid, as we know, the sources, as we have deal with food is your broccoli and spinach, lentils again, so your legumes. Romaine lettuce has quite a lot of your folic acid, and at times you may be recommending certain doses, especially for other people as you get older, etc. Folic acid supplements. Soluble fiber for cholesterol. I think everyone knows that once you get cholesterol, they take Quaker oats. So your client comes and they said, I'm taking a lot of Quaker oats. So the oats, yes, is good to be taken, but that in itself is not alone. It's change your lifestyle in order to benefit reducing the cholesterol and reduce the risk of coronary heart disease. So these are some of the foods that has soluble fiber. You see your legumes come in handy there. Sweet potato is useful here. Your apples. The problem with the apples today is that because of the skin of the apples, because of what they put on it is maintain life, that it can be a problem for certain people's stomach. So I tend to advise that some people do peel the apples, or you can scrub it with one of those scrubbers to remove some of those barks. Oats and barley. Barley is excellent. Your oatmeal, and if you're doing oats, rolled oats and stick cuts oats are the better options, okay? And the next thing is soy protein. Research has shown that it does reduce your LDL cholesterol and total cholesterol. However, some people are a bit, coy of using soy protein, especially if you have cancer and other things. So, but it does reduce your LDL cholesterol. And these are some gums that you can use. And if you look at this slide, you see oats are quite useful. They are good. Psyllium husk is one that is higher, that reduces cholesterol, but oats came in second there. And your beans, so your natural food in itself will do the trick instead of doing the metamucil and other things. But if it is that you have to use it, you can benefit. That benefits you, okay. But as you can see, the oats and the beans also are very useful in that research that was done. So the primary prevention of cardiovascular disease, cancer, and other lifestyle diseases, healthy diet and control of major risk factors remain important. So it's not one food, but lifestyle is important in order to ward off some of these NCDs that is plaguing our population. And this slide is showing you that we can start with lifestyle intervention, eating healthy before the problem comes on. And then if your problem, God forbid, lifestyle and healthy eating comes in play. So it comes in prevention, it comes in the management, and it also comes in the complications of certain diseases. So your primary, and secondary prevention, lifestyle, healthy diet comes in place. And this shows you how effective that is. So let us look at weight loss. It is complex, but you know the benefit of losing weight. But like I said, with the fat, if you're not active, you can have normal weight, but high fat, which is also predisposing you to cardiovascular disease. So activity is very important. So healthy lifestyle includes your physical activity and eating properly or eating healthily. So if we are looking for changes, we no longer someone comes to us and say, we will help to reduce you to your ideal body weight. Ideally, if you're, we try to reduce about 50% of excess weight. Because the reason for that change is that most of them cannot achieve it. I'm sure you would have looked at the Big Loser on television, and most of the time they all put back on the lid. They work so hard. So we gradually will ask the person maybe to lose 5 to 10%. So we give them guidelines for that. We plateau there, and then we move on again to lose maybe 5 to 10% again, and then change again. So it is not, and you plateau. So it's not a fix that you're going to rush and lose it, because you put it back on as quick as you lose it if you do not really put systems in place to prevent that. So we have to be clear of what treatment can and cannot work. So again, like I said, we don't go to ideal weight. We just discuss biological limit, we focus on non-weight outcomes. For example, if you're diabetic, your blood sugar is working well, your hemoglobin A1C when it goes back is lower, your cholesterol is going down. So these are some of the things that we look at. And eventually, the weight is going to come in place. But we don't focus on the scale. And if you're focusing on the scale, you have to focus on the total body composition, because the weight itself alone is not going to tell you exactly what is happening with your patient. They can lose weight when they come back with a scale alone, but yet they would have lost body water and they would have lost lean tissue. So a body composition scale can help you, and you also add the outcomes of their medical condition, which is being improved. This slide shows the Harris-Benedict formula, which you can use to determine your basal metabolism rate. That is the amount of calories you need to sustain your body. If you worked it out, that weight, that amount of calories you can use when exercise and lose weight without having been detrimental to use. If you use less than what your body needs, then what you're going to do, your body is going to go into sort of a hibernation, and then what we'll do is that you will hold on to the fat, and you're going to lose lean tissue, and your condition is going to be worse, and you're more prone to more medical problems. So use this, and even if you go 100% less, so like for this, if you use the slide here, for ladies, most of you, it will be anywhere, if you're very small, 1100 calories. And it can go anywhere between 11 to 1400 calories. Guys, it may be about 1800 calories, depend. Obviously, if you have activity on that, depends on your type of activity, you add to that. If you're not very active, etc., then you just use that metabolism in order for you to lose, help the individual, your client, to lose weight healthily. So let's look at alcohol. As this first slide, you show alcohol with diabetes, alcohol with hypertension. Alcohol is protective, and as you saw in the Mediterranean lifestyle, they drink wine. But there are also risks to drinking alcohol: breast cancer, liver disease, hypertension, stroke, etc. So there's a protective mechanism. What we are suggesting is that, yes, you can drink alcohol, 2 drinks per day for men, 1.5 drinks for women. And the drink is 6 ounces of wine or 12 ounces of beer, etc. But the thing about this is that even though I say 2 drinks a day for men, that is on a daily basis. If on the weekend that you lose because in school or doing whatever, you didn't take your 2 drinks, it does not say at the weekend that you have 14 drinks. You miss it, you lose it, because you will lose your protective mechanism for heart condition if you consume too much of it. So 1 drink a day for men, 1 for ladies, which you can have with your dinner, etc. And this is a mechanism for the protective effect of your alcohol, wine, etc. And they're saying now is any alcohol is protective, with the hard stuff or wine, etc. However, if you have high triglyceride, alcohol is contraindicated, so that you should not be consuming alcohol if you have high triglyceride. Just as I said, we do not give us high carbohydrate if you have high triglyceride. The same is with the alcohol. So if the patient has that, we tend to reduce it or ask them, cut it down, don't take it all together until they can go to a limited amount and cut down on the amount of carbs that they consume. The blood alcohol concentration is what you need. You know that we are testing, the police is testing the blood alcohol level, so you need to know the numbers that you're supposed to be at before you drive your car. That yourself that you shouldn't be driving and drinking. And if you go out, you always have someone that designating. Let's move on from alcohol to fish oil, and we know that triglyceride also, and increases, a small increase in your HDL, which is your good cholesterol. However, and we also have the long-chain omega-3 fatty acid in plant sources. But the omega-3 in fish, we have to remember that they are mercury poisoning in the large fish. And I did put a slide in that has the fish that has high amount of mercury and those with low amount. So it depends on where they catch the fish and the type of fish that will have the low amount. And you will see that mackerel and herring, etc., those are the ones that has low amount, because the small fish are the ones that will have less of it. The big fish, the sardines that we have, all of those things have less. And some salmon, and the salmon depends on where you catch your salmon, compared to the ones in the high level. And the salmon, if you get it in the Atlantic, etc., or you farm, those are some that may have higher mercury. And as I said, because of vegetarian, this is a list of omega-3s for people who are vegetarian, or even for people who we tend to say, or pregnant ladies also, not to eat fish only twice a week, and they can still get the omega-3s from vegetarian sources. Another criteria is for you to ask your client or your patient to read labels. And what I have to say is that you have to look at the serving size, because on the label, you may see serving 300 calories, and you have to look and see how many servings in that. So it may be 2. So the 300 is for 2 servings. The 300 is for 1, so that whole pack has 600 calories. And if you look at ingredients, what is on first on list of the ingredients is the principal ingredient in that product. So if you see sugar first, that's a sugary product. If you see sugar second, it still have a consume. Those are the least level at the lower end. Those are the things that have less of it. So that's what you have to look at. And sometimes you may see something that has no cholesterol. It still has cholesterol in it. For example, you can say no cholesterol even though it has 20 or less. And if you eat that product and you say it has no cholesterol and eat a large amount, you can build up your 300 milligram by just eating that and thinking that you are not consuming cholesterol. Low fat, 3 grams or less. But what I want you to look at is the sodium. Fewer than 140 milligrams of sodium per serving. And you see how high the sodium it was in the products that we look at, the burger and other things that we looked at earlier. So this is important for your client to know what is low sodium, low fat, etc. Sodium, where do we get the sodium from? We put sodium in the food. And as you know, the DASH diet was useful in lowering blood cholesterol and sodium in lowering hypertension. And this research has shown you that reducing the sodium in the diet, eating more fruits and vegetables like the DASH diet, definitely has shown to lower your blood pressure. So DASH diet is useful in doing that. And we have Mrs. DASH. If you have high sodium, high blood pressure, you can use less salt by using Mrs. DASH. And these are plant-based foods that can be useful that I put on because of other people, because we are moving on to plant-based food, many persons. So if you look at change in the therapy for diabetes, I just have to move on because I have quite a video to do. We emphasize macronutrients and percentage, and some research which you can tell your client, and Cornell University, this research was shared with at the Hyatt with the Medical Association board at a meeting a couple of years ago, 3 or 4 years ago. And what they suggest is that from their research, if the diabetic patient consume meat and their vegetables first and 10 minutes later eat their carbs, they have shown that they less drugs than they're needed, and they get a better control for their diabetes. So maybe this is useful for even for people who have pre-diabetes, that they can start doing that so that their blood sugar is not going to go that high. So our prioritize is focus on carbohydrate food, portion size important, protein and veggies eaten before carbs, encourage physical activity, use foods record because they should write down. Emphasize the blood glucose and other things instead of the weight loss. And these are some of the focus that we are looking at. and glycemic index of food, low glycemic index of food, we tend to advise having lower glycemic index of food, like for example, green fig. In the carbs, it has a low glycemic index in your provision, and sweet potato. If you look at rice, basmati rice has a lower glycemic index than our regular rice. But beans, like legumes, has a low glycemic index. So if you're using our regular rice, what I normally say, use more beans than rice so that you will have a lower glycemic index with your food, which is better for the diabetic patient. So to summarize or to finish, I have to speak a little on end-stage renal failure. And these are the risk factors: diabetes, hypertension, family history of kidney disease, cardiovascular disease, etc. And what we try to do is that most of the end-stage people, renal disease individuals tend to have malnutrition. So we're trying to avoid the malnutrition and slow the progression of their kidney condition. As you know, they get disturbance of water and electrolytes, and they have poor energy intake and protein due to the anorexia. There's a buildup of waste, and that's why nutrition comes in here. So we give them a plan which will help to reduce the buildup of waste within their body. And these are the considerations for dietary: protein, energy, fat, sodium, potassium, phosphate, fluid, and vitamins and minerals. So these are why we restrict protein. And protein is the first thing that we look at first, and we determine how much protein the individual will have before we add other nutrients on. We want to reduce blood urea, minimize the rheumatic symptoms like itching and all of that that may happen with your client, and we want to slow the progression of the condition and reduce phosphate load, prevent the bone problem because they tend to get osteodystrophy. So this is an exercise which I will go through. For example, the non-diabetic patient, we tend to give them 0.8 grams protein per kilogram body weight, which is important, and diabetic either 0.8 to 1 gram per kilogram body weight. Previously, we used to give 0.6 grams per kilogram, but it's difficult for the person to adhere to that diet, and it's only given to non-diabetic patients. And sometimes what we have seen is that they use their own body protein, which makes the accident condition worse. When we are looking at protein, we look at high biological value protein like meat, fish. We have the essential amino acids higher amount than the low biological value protein. Hence the reason why we try to give more of that, because your body is going to utilize it more effectively than the low biological value like nuts, beans, etc. And staples also has protein. Like a slice of bread will have 2 grams of protein, your sari roti, quarter sari roti, pasta, provision, etc. And other grains which we are encouraging people like quinoa that has more protein than the rice, etc. So for example, if somebody is a diabetic and the person is 70 kilogram, because we have to give 0.8 gram and we're using that in this exercise, it comes up to 56 gram protein for that individual. That, in order for that 56 gram of protein, that person can only have 4 ounces of meat for the day. They can only have 8, if I use a slice of bread as a serving, 8 servings. So that 8 slices of bread, a glass of milk, 0.5 grams of protein in 1 serving of fruit, 4 servings of fruit, and 3 servings of vegetables. And that to work out the 56 grams of protein. 1 serving, which is a pot spoon of legumes or half cup, has 4 grams of protein. If the person's potassium is high, then we would not use the legumes. However, if it is not high and the person is vegetarian, even though it is high, because they would not be eating meat, we have to modify and use legumes to fit into the post so that the patient will get adequate amount of protein so that they will not use their own body protein. So important is that energy intake must be sufficient, because if you don't have adequate amount of energy, you will use the protein that I'm giving the client for energy, because that's your body's first need, energy. So we have to ensure that they have adequate amount of fat, amount of carbohydrate in order to give the energy so the body can utilize the protein effectively. So we don't want them to use their own body protein, which will make the situation worse. So the energy, because I said that most of them die from malnutrition, so we need to ensure that they have adequate amount of energy-dense food. adequate protein so that it can hydrolyze for rapid absorption. With regards to fat, we give your polyunsaturated to saturated 1-to-1, and 30 to 40% total calories coming from fat, in some cases 30%, in the pre-end stage. But once they have end-stage renal failure, they tend to have high lipidemia, hyperlipidemia. So we tend to give 30% of fat, and we increase the monounsaturated in more with that 30%, where maybe 15% could be monounsaturated, so that because of the hyperlipidemia that the client may be having. So we limit the fat, and we increase the monounsaturated, limit dietary cholesterol. Sweets, especially if you're diabetic, we don't have, but non-diabetic we can give in order to help with the energy. Alcohol, definitely, the limit, and complex carbohydrate. One thing about potassium, it causes arrhythmia. So if it is not pre-end stage, we don't restrict it. But once it's chronic renal failure and they have reached that stage, end stage, we have to restrict it. So there are certain foods that we have to reduce and tell them, tell how much to be used. However, there are certain high potassium food that should not be used. As you see there, the bananas, the green figs and potatoes, etc., high. What they can do, because they are low in protein, and they have to use it, they can soak it overnight to remove some of the potassium, we call it leaching, and prepare the following day. One thing is important, that before they had end-stage renal failure and they had hypertension, we would have said use Mrs. Dash. Mrs. Dash is made with potassium. So in this case, they do not use Mrs. Dash, and they tend to say that we are confusing them. Use it now and do it, use it now. Hence the reason why we have to explain everything to the client, why we are saying not to use it now, because of the potassium effect, and the potassium is getting high and it can have problem with it. Phosphorus we tend to avoid, and what you do, you give phosphorus binders. You'll be referring prescribing that for them, and these are the sources which we tend to adjust in the diet based on their phosphate level. And sodium, again, we spoke about sodium, which will cause fluid retention, and all these foods that we tend to ask. And in a healthy lifestyle, these are the foods that we avoid anyhow. So with them, it's like a norm that they should not have been consuming these before anyway. Vitamin minerals, we may have to give some to prevent the renal osteoarthritis that they tend to get, and maybe the sun, vitamin D, iron sometimes based on the doctor when you see their levels, and folate sometimes to avoid anemia secondary to folate deficiency. These are some of the things that you will be prescribing. We will give it in food. And some of the dark green leafy vegetables, which has folate, may have a lot of potassium. So again, there's a balance that we have to use with these guys. Fluid, if they are not retaining water, we don't restrict fluid, because if the person is dehydrated, it makes their kidney function worse. So we try to avoid dehydration unless we restrict fluid on if they are definitely retaining fluid. So it is important that we be realistic, we avoid setting perfection as a goal, and we have to review the client ever so often so that we can also continue along, encouraging them to make changes in their life. So these are certain tips for eating less fat. Choosing lean cuts of meat, fish, grilled, steam, choose healthier snack, brown meat, without lots of oil and sugar. Less sugar to recipes, use extra vanilla, etc. White meat, egg whites you can use instead of whole egg. But like I said, you can use 1 whole egg a day. You want more eggs, use more egg whites. Natural herbs, garlic, black pepper, etc. Olive or canola oil, palm spray if you or fake fry. You can get an air fryer and you can fry in that instead of using a lot of oil for frying. Like they said, which is normally said, when you shop, like these are the things that we tell our client. Make a shopping list, stick to it, prepare food, eat when hungry, drink lots of water. And these are some of the behavior change that we advise clients to take. Replace bag processed snacks with more healthful snacks. Tree nuts, fruits, vegetables, swap soda. We spoke about soda and juices previously. Fresh fruits, etc. But then again, diabetic, we have to take the portion size. And you can use that for dessert instead of ice cream. Yogurt, you can use also. You have plain yogurt and fruit. You can use that so that you reduce the sugar going into your system if you use plain yogurt with fruits. And eating together, sometimes you may eat together and slow down the eating process. You won't be eating that much. Snacking in between. And you have to remember there is no one size fit all. So do not send the patients to us for diet sheet. Please, it's an individual meal plan. Food with fat, we definitely use because we want the essential fatty acid. So we have some to moderate, but not to eliminate. Use a lot of fresh herbs. And these are the antioxidants that I was telling you about because of the COVID. Vitamin E is an antioxidant. You see avocados there, nuts, wheat germs, whole grain seeds. Beta carotene, deeply pigmented fruits and vegetables, red, yellow, etc. Vitamin C, Brazilian cherries has one of the most source of vitamin C. You have citrus fruit, guava, even guava, tomatoes, broccoli, strawberries. Selenium is another mineral that is antioxidant. You get that in seafood. Brazil nuts has a good bit of selenium. Again, you can put that for antioxidant in your snack basket. Zinc, you get that in crabs. Remember, we're looking at lean steak, and I said lean ground beef if you want to, but lean again, poultry, legumes. Phytochemicals like lycopene in tomatoes, isoflavonoids in soybeans, and flavonoids in apples. All of these things, your turmeric and all of these things will help with the antioxidant to strengthen your immune system. So antioxidants at a glance, I use the Mediterranean pyramid in order to, at a glance, to identify some of the antioxidants that we can use, and we can use our plate model to identify. So this slide shows identify some of the antioxidants that I've been speaking about. Hydration is important unless you have renal disease and having a problem that we have to reduce water, but drink your water, 2 liters per day. Sip instead of gobbling the whole glass of water. And finally, there's no shortcut to any place worth going. So I want to say thank you for listening, and if you have any questions, we can ask some. If you have any questions, you can do that. Ask that now. Are we still here, or did I put you to sleep? Hello. Okay. Any questions? No? Okay, so we have 10 minutes. So if you have no question, I am finished, and thank you very much. Yeah, the peace of mind. If you was listening to the lecture, and if you thank you, very important. Thanks. Thank you. Okay. Thanks for listening. Thank you. Okay, I'll reply to, I will cover the questions. Maybe I can cover the question and send it to my learning. Since we are finished now, we may have a class after me. So I'll cover the questions and send it to you because somehow I was not seeing the questions. Someone asked if this today's session will be recorded. I am not sure, but I did send the PowerPoint to put up on my e-learning for you.
Dr. Batson?
Yes.
Karen? Right, the session was recorded.
Okay, great. Somebody had asked that question. Very good. Thank you.
Yes. You're welcome.
Any other question? I'm not seeing any other. They had asked. Yes, lovely presentation. My nephew not eating pizza again. Okay, I'm not seeing any other questions for me to respond to.
No, I'm not seeing any either.
All right, thank you very much, and all the best.
Okay, thanks.
Thanks a lot.
Thanks. Thanks, Dr. Batson.
You're
We'll
welcome.
chat.
Yes, we will.
Okay.
Okay, bye-bye. Okay, bye.
Bye-bye.